Well, thank you very much indeed. So there's a 1 in 5 chance of you developing heart failure. And looking around the audience, I think it might be slightly higher than 1 in 5. So please pay attention. This may be very relevant for you and your family. And what we're trying to achieve, of course, is not just good processes of care, but good outcome, but increasingly a good experience of care. I don't know if any of you have used health services recently, but that's actually a really important element of satisfaction. Now, NICE came in for a lot of flack. Let me tell you, I'm the only clinician on the board of NICE. The comments were received, and we are trying very hard to be faster about producing new guidance. But you can imagine across all of medicine now, trying to update everything as quickly as possible is a big challenge, but we understand that. So NICE has given guidance on heart failure, so it's very clear for the NHS, at least in England, what good looks like. And I'm just going to give you the highlights of this. So when you do get breathless and you have the test that suggests you've got heart failure, you go into the consulting room knowing exactly what should be happening. Just a quick anecdote. I had a patient that came to see me recently for a third opinion. Very aggressive, tall guy, came in with his briefcase, wouldn't sit down, all the signs were bad. And he said, I've got heart failure and I've been treated badly elsewhere. I said, well, that's interesting. And then he said, and I've read the NICE guidance on heart failure, so I know what I'm entitled to. I said, well, sir, can I suggest you sit down since I wrote the guidance? We got on fine after that. But it is about expectations and being able to deliver. So this is diagnosis. So obviously, particularly at an Oslo centenary meeting, it is about history taking. It is about examination skills. But then there's one very simple blood test, hashtag one simple blood test on social media, which will help sort out whether it's likely to be heart failure or not. And that's the natriuretic peptides, usually N-terminal pro-BNP. And that's the gateway then to saying, well, you might very well have heart failure. Let's do some investigations and see what's wrong with your heart. And echocardiography is a usual imaging modality that will give us lots of information quite easily. So those are the particular cut points, less than 400, very unlikely to be heart failure. Think of something else. Above that, it might not be heart failure, but you are at risk. You probably have cardiovascular and renal problems, and you certainly need assessment. This is the actual algorithm. You can see the pictures much easier, but it's just making people try and be systematic about people with breathlessness or ankle swelling or fatigue. But eventually, you end up at the bottom of the algorithm. This is heart failure, and we kind of split it very simplistically into reduced ejection fraction heart failure, or systolic heart failure, the old term, or preserved or normal ejection fraction, HFpEF. It's slightly more complicated than that, but just in the interest of time, we'll focus on that. So in the middle there, patient has an MI, has some damage to the heart muscle, the heart dilates, used to be the most common cause of heart failure in Western Europe. And then on the right-hand side, you've got HFpEF, which is diastolic, stiff ventricle. It actually contracts well in systole, but it's stiff, pressures go up, get very breathless on exertion. Got a little bit of left ventricular hypertrophy, the left atrium's large. You're usually older, more likely female than male, and history of diabetes, hypertension, etc. So those are the two broad forms of heart failure. And enormous success for the middle category. We've got an enormous number of new therapies for this area, and you will do fantastically better than you would have done 10 years ago even. HFpEF, a bit more of a challenge, and we'll come on to that. So what drugs should you be treated with when you do develop your heart failure if you don't have it already? Looks quite a complicated algorithm, but it's actually quite straightforward. So if we look at reduced ejection fraction heart failure up here, ACE inhibitors, beta blockers, aldosterone antagonists, been around for a very long time, very effective therapies, triple therapy as we call them. And actually nowadays in the NHS, we'd expect GPs to be able to titrate such therapies. And then there's a specialist box here, which I'll very briefly dip into. Things like sacubitril valsartan, the beta RAS inhibitor, ivabradine to slow your pulse down, and one or two other bits. So in terms of these specialist therapies, sacubitril valsartan, or the trade name is Entresto, a very big study was done with this agent, stopped early because of overwhelming benefit compared to high-dose ACE inhibitor. So this is very rapidly becoming the go-to RAS inhibitor for systolic heart failure. What is it? It's a combination of valsartan, you're very familiar with, AT1 receptor antagonist, so all of these good effects, but also this drug here, neprilysin inhibitor, which blocks this enzyme. And so you then end up with high natriuretic peptide levels, high histamine, high bradykinin, high substance P, you name it. All these vasoactive hormones are also increased. So you get two effects here. Vasoactive peptides go up, and you antagonize the AT1 receptor. Drops blood pressure more than an AT1 receptor on its own, as you'd expect, but a really big difference in outcome. So a very big trial called Paradigm. The investigators were lucky calling it that and then having a game-changing result. So it's stopped early by the ethics committee, and nearly any endpoint, I've just chosen the primary endpoint, but it was the same for cardiovascular death, same for heart failure hospitalizations. Even compared with very high-dose ACE inhibitor, patients did much better right from the get-go, about 20% better. Look at that p-value. Have you ever seen a p-value with so many zeros? This is really very unlikely to be due to chance. And the number needed to treat in terms of absolute benefit, really very important. So this is very much supported, and in specialist practice, people are coming off their ACE inhibitors, angiotensin receptor antagonists, and going on to this drug, provided their blood pressure can tolerate it. What about another one, ivabradine? Well, this is a heart rate lowering agent, completely independent of beta blocker receptors, so you will still get further heart rate reduction, even if you're heavily beta blocked. This is the world's cheapest biomarker. If you can spare 15 seconds and multiply by 4, you've got the answer. So I'm very keen on this in the wards. No expenditure, you get the answer to the question. And what we do know in sinus rhythm, not in AF, but in sinus rhythm for heart failure patients, there's a very clear relationship. The slower we manage to make you, the better you will do. And this is in all data sets. So beta blockade, of course, we try to get the heart rate down in these patients. Sometimes it's not very tolerated at high dose, sometimes not tolerated by the physician as well as the patient, but we can add ivabradine and drop the heart rate further. The actual hyperpolarization channel is involved, so it's just in the sinus node in man, and what it does is just slows down depolarization. Your RR intervals stretch and your heart rate goes down. And the patients notice it. They say, oh, doctor, that's great, that new tablet. My pulse is 10 beats per minute slower. Super. I've only got so many heartbeats, so obviously you're making me live longer. And actually, there's quite a lot of truth in that statement. So I go, absolutely, you've got the idea. This is a big trial, the SHIFT study. Thousands and thousands of patients, systolic heart failure, very well beta blocked, and on all of the other agents. You drop the heart rate further. On average, it's about 10 beats per minute. Tends to work less if you've got a low resting pulse rate, so it's kind of built-in safety mechanism, and it has the biggest effect if you've got a high resting heart rate. And this is what it did. Cardiovascular death, hospital admission, down by 18%. Hospitalization for heart failure, down almost 30%. Big impact on stability of the syndrome. Total hospitalizations the same, and even dying from pump failure down. So slow the heart down in systolic heart failure, more stable, less likely to decompensate, less likely to die from pump failure. So this is also now part of standard practice. So you need a nice slow heart rate, RAS inhibitor, beta blocker, aldosterone antagonist. So that's all great. Super. We'll keep you out of the cemetery for a few more years with giving you these therapies. What about HFpEF then? So you've got heart failure, we do the echo, and the ejection fraction's good. But we can see that it's a stiff heart, big atrium. What therapies do we have? Well, we have diuretics, very good at relieving congestion, making symptoms better, but do we have anything to change outcome? Well, it's not for want of trying. Each one is a different trial, so this is probably $100 million for each one of these blocks, so I'd appreciate if you looked a little bit more interested in the results of these. So this is candesartan, AT receptor antagonist. This is perindopril. This is irbesartan, another angiotensin receptor blocker. And this is even spironolactone. You can see neutral, neutral, neutral. Still not very impressive, p-value 0.14. And then, of course, we have this huge political controversy, just as a kind of side note for you. When they looked at the data in this trial of spironolactone, which a lot of us do use for HFpEF because of its diuretic effects, And they split it by Russia and the Republic of Georgia. I don't mean the state, but the Republic of Georgia versus the rest of the world. You can see the Russians were recruiting probably hypertensive patients that didn't actually have heart failure. So very low event rates and no change with spiro. The rest of the world was recruiting much higher risk patients, probably the target ones. And you can see here, just was significant. So what's the interpretation of this in a Trumpian era? Well, if you're in North America, we know how to use a drug. We think it works. If you're in the rest of the world, you go with this and say, actually, the hypothesis wasn't proven. So we don't know what to do. But a lot of us do use spironolactone. Bang up to date, just published in the New England Journal a few weeks ago, presented at a big conference in the summer. This was the Entresto, this sacubitril valsartan. Really, really good for HFrEF. What about HFpEF? Big trial here, almost 5,000 patients, comparing this with valsartan on its own, and oh dear, look at this. If you're a frequentist, you say, well, hypothesis wasn't proven. If you're more an optimist, and you say, well, it was almost proven, which is not very helpful, actually. But if you then split it into these endpoints, it's a weak signal that it might stabilize the syndrome, a little bit less hospitalization, but absolutely no signal that you're changing death rate in this type of heart failure. So very, very different from HFrEF. But interestingly, if you combine the studies together and you just look at the effect across ejection fraction, so just to orientate you, this is no effect here, the line of unity. This is ejection fraction. So this is way down at very low levels. You can see this drug is very good at reducing event rates all the way through ejection fraction up to about 55%. So this is HFpEF, no evidence of benefit, but any signs of systolic abnormalities, it seems to be very good indeed. So this is a simple interpretation most cardiologists make. HFrEF, sacubitril valsartan as a RAS inhibitor. HFpEF, it's about symptom control, and let's hope some of the other studies we're doing will be positive. And so, picking up on Professor Chowdhury's talk, he was waxing lyrical on the SGLT2 inhibitor drugs. So, as a cardiologist, I'm delighted at last the diabetologists have understood it's all about heart failure. So he's right in his enthusiasm. So let me show you the exciting data that took us all by surprise for the use of SGLT2 inhibitors in heart failure. So there are lots of mechanisms of action, and as you know, if we have a slide as complicated as this, we don't really know how it works. It changes lots of things in the body, and intrinsically, how all of the tissue handles sodium and water, not just the kidneys. Here was a study, DAPA-HF. None of us really thought it would be hugely positive. A large number of patients with or without diabetes. So we were giving this so-called diabetic drug to people that weren't even diabetic. Now, the great thing about SGLT2 inhibitors is that they don't induce hypoglycemia, so you can do this. Typical sick heart failure patients. This was the result. No difference between whether you had diabetes or not. Look how quickly the difference emerges in these very important endpoints. Almost from the first tablet, your heart failure behaved better. So these are not diabetic drugs. Don't let Professor Chowdhury fool you. These are cardiovascular risk-reducing drugs that happen to have a hypoglycemic effect in those with diabetes. Okay? You heard it here first. Worsening heart failure. Look at this. From the first tablet makes a difference. Cardiovascular death even. It wasn't powered for this, but look at that. Almost 20% reduction in cardiovascular death. So this is a game changer, and it's not yet licensed for heart failure on its own. And we don't know what the regulators will make of it. We don't know what NICE will make of it as yet. But I suspect it's a fire and forget type tablet with very few side effects. So it probably will become important. Just to show you, absolutely no difference in the effect, which is very positive, in whether you had diabetes or not. Now, I want to finish off with digital and how we get the patient living with a chronic condition. And how do we manage that workload? How many of you have a smartphone? Nearly everybody. How many of you have an Apple Watch? 1, 2, 3, it's going up. Wow. So, somebody's got one on order. So you're moving gently in that direction of the modern world. Fantastic. So let me just share with you the journey of the last 20 years of digital in this space. So digital is everywhere, every aspect of our life. Healthcare is quite slow to move into this for good and bad reasons, but the politicians think we're all Luddites. We're all very resistant, overpaid, over-egoed, over-trade unionized. We need to modernize. So if you go to the discussion with the tech companies and the politicians, you will not like the discussion. So we need to be part of that discussion and conversation. So there's me now. What's going to happen in 10 years' time? I'll be retired, so I don't care. But, 10 years from now, what will the role be? It'll be much less face-to-face. Obviously, if you need a procedure, you might need to have somebody there doing it. But actually, artificial intelligence to supplement and maybe take away some of the drudgery work. Internet of Things with everything connected together, including wearables, collecting all sorts of information. We'll come back to that. And even drones. You're not going to run out of your medication, because as soon as the packet gets nearly empty, signal will be sent through the Internet of Things. You get up in the morning, you open your packet, you think, oh my God, it's the last tablet. You hear a drone coming down the street. You open your window, it comes in and drops a packet on your dining room table. I don't know why you're laughing. This is all possible even now, and it may well be going in this direction. Look at this. This is a tech conference in London very recently. The data will see you now. Not about physicians, healthcare professionals. There's this belief that actually AI and data will solve all our problems. So here's some examples of actually, we've been doing this for many, many years. This is the first ECG machine. It looks as if it might electrocute you rather than record your ECG, but you can see it. Most of us were brought up with these machines here in the emergency room or clinic, but your patient had to come to the facility. By the time they arrived, of course, their palpitation had settled and the ECG was normal. It's all very frustrating for everybody, but we were in control of recording it. It's a Cardia device, a live call, clips to the back of your smartphone, 2 thumbs, you get a nice ECG recording, used now very widely in the NHS and prescribable by a GP. Here's the Apple Watch, where you can actually record it. I do have one. But today I'm wearing a Cartier for different reasons. But you can actually record your ECG just by touching your watch for 30 seconds, and you get it here. New England Journal of Medicine, 14th of November. I'm not rehashing an old talk, folks. This is brand new, okay? New England Journal of Medicine, just a few days ago. This was the Apple Heart Study. 400,000 people with an Apple Watch, seeing how much atrial fibrillation you could detect. Small number, because these are generally young people wearing an Apple Watch, but of those that were detected, a lot of them were found to have AF on further testing, so probably important. This is also interesting. Even those that signed up to the study, only 60% of them took any action, even when told they might have this cardiac problem. So, of course, human factors are still important. What was the reaction of the medical community? Well, Milton Packer, big heart failure guru in North America, quoted as saying, this is the worst heart device ever. So here you have all the excitement in the press from the consumers and a physician going, the worst thing I have ever heard in my whole life. It's not a great way of moving forward. Our own president of the Royal College of GPs until very recently was all about how busy GPs are and how they couldn't possibly cope with health-relevant data that might be important for their patients. Too busy, can't do it. I was asked to give an interview, and I thought I better be careful not alienate all my colleagues. So here we are. It's not as good as a full workup by a doctor, so that's good for us physicians, but it's an interesting step forward in flagging up heart problems early. So hopefully keeping both the consumers and the physicians happy. But this is where we're going with all of this. Another example, stethoscope. Most of my junior doctors have given up buying a stethoscope. And when I say, has anybody listened to this patient's heart, they hand me the echo report. I then just say, did you hear what I asked? And they still hand me the echo report. Little devices, you can hold it to your chest, record an ECG and the phonocardiogram. This is a robot that can do your echo. It doesn't even have to be in a hospital. It could be in Lidl. I don't know what that is, but I think it's a store. You could just go in there and have your echocardiogram done whilst you got your shopping. And images interpreted by AI pick up the major abnormalities, then fine-tuned by this, but you don't have to go anywhere near a health facility.
to get very detailed health information. The question is, can you make sense of it? Who's going to look at it? Who's going to take responsibility for it? Another example, on the tube, have you seen these adverts? Babylon Health, resign from your general practice, and you can have, just with your smartphone, a GP on your phone within 5 minutes if you need to. Yeah? Problem is, you have to resign from your general practice. They don't take chronic conditions, pregnancy, mental health. So what does that leave? Probably sexually transmitted diseases in students. But you get the point. You're quite a hard audience, actually. You can laugh. It's absolutely allowable. But this is what people are doing. They're saying, we don't like the systems you've set up. They're too slow. They're too clunky, too inconvenient. Here's somebody offering something else. We're going to go for it. And I think that actually reflects a lot of dissatisfaction with some of our current structures. The Metro newspaper, just very recently, Alexa will do the job of my GP. Just speak to it, wired into NHS website. What do doctors think of this? They were asked a question by a social media site. Do you think it's great, or it's a bad idea, or it's complicated? Guess where our colleagues voted? We have no idea. Really no idea about whether this is good or bad or where it's going. But ultimately, it is about the person living with their condition. How do they optimize their outcome in their terms and just access the expertise when they need it and in a much more convenient way? And keeping the MD out of this because they're slow and clunky and you're actually trying to speed it up. So just very quickly in the last 5 minutes, putting together 20 years of research on remote monitoring of heart failure. So lots of different things, TV-based, and you can see the weight that's been set for this patient. They can see what their daily weight's doing. They get a flag if it's a problem. They can adjust their diuretics, phone for help. That seems quite straightforward. Implantable devices like ICDs or CRT, lots of information for free that you can look at. And then this tiny little chip that you put in, just implant in the pulmonary artery very easily, and you can actually measure the pulmonary artery pressure, and I can look at 25 of my patients' pulmonary artery pressure every morning whilst I lecture at the Royal College of Physicians, and then just email the team to say, do this, do that, etc. So where are we going with this? No shortage of things we can monitor very cleverly, lots of engineers. Small initial studies were hugely enthusiastic. Huge publication bias. Editors don't like small studies that are neutral. They're not going to publish them. Small study that's hugely positive. Oh, we might be the first to get into this space, so let's publish it. So you end up with just monitoring patients, mortality benefit, almost 40% reduction in mortality. I don't think so. And then hospitalization also, big benefit. But these were tiny studies from very enthusiastic centers. So cardiologists said, we need bigger studies, more generalizable studies. And that's where the wheels came off the wagon. Big US study, New England Journal, 2010, absolutely neutral for every endpoint, for every subgroup. Now that was phoning a telephone line, a bit like phoning HSBC, press button 1 for this, press button 3 for this. Then after 20 minutes of pressing buttons, you go back to the start. Not great. So a lot of patients didn't actually phone the helpline ever, despite going to the study, and 60% had stopped by 6 months. So let's get rid of that one. It's a bit clunky. It's not really remote monitoring. Let's move to Germany, where everything is much more controlled. This was a central 24/7 telemonitoring center in Berlin at the Charité Hospital, which I know well. And the GPs were involved, and the patients, and the families, and the local cardiologists, and the ambulance service. What was the result? Absolutely neutral. Surprising. So let's move from old Europe to the modern world. Let's move to California. Everybody has a light tan and possibly white teeth. It's bound to work. They did it absolutely neutral for all endpoints. You can't improve on conventional best care from specialist centers, but maybe you can increase the reach with this. So let's abandon that, and a lot of policymakers stepped back and didn't reimburse that. What about here, where the implanted system, like a defib, giving you all of this physiological information wirelessly, Bluetooth? She's not a typical heart failure patient. She's a bit younger than our typical, and obviously just newly married, as they seem to be very close to each other in the bed. But you can see the information that you could look at, in theory, every single day. And we did make a difference. Here's one where we had an alarm that went off in the device if you crossed a threshold. Look what we did. We increased heart failure hospitalizations by 80%. How did we manage that? I mean, don't let anybody tell you we don't make a difference. We do. In the wrong direction. And the reason was this. You're a heart failure patient. You wake up in the morning, you think, thank God I'm still here. Not quite sure how I'm feeling. Let's move one leg out of the bed. Might be a good day. Let's see. Have a cup of tea. Reading the newspaper. You're going, today's going to be a reasonable day. Suddenly, your alarm goes off in your device. It's a very loud auditory alarm, like an alarm clock. That person starts to get anxious. They start hyperventilating, feeling more breathless. They phone their son at work or their daughter at work saying, I was feeling fine, but my alarm's gone off, and now I'm not sure. I think I am more breathless. The son's going, oh, for God's sake, this is the least convenient day ever, but I will come and see you. They go there. By now, the patient's so hyperventilating, they're lightheaded and unable to do anything. Take them to the emergency room. The emergency team say, well, you look fine, but let's just be on the safe side. We'll admit you. See what happens. These were short admissions. Nobody died during these admissions. It was just overreaction to the data. So why don't we just not take one thing to alarm, but we take a whole lot of things, and by clever maths, you can produce this real big difference between high-risk and low-risk patients. That looks great, but if you actually look at the absolute risk, still only 7% in the next month. So in other words, 9 out of 10 patients, even with everything in the wrong direction, will restabilize without any intervention. This is the world's largest study. It was done in England, in the NHS, 9 hospitals, by John Morgan from Southampton and myself. And have you ever seen a study that's had a hazard ratio closer to 1? 1.01. No improvement on specialist care as conventionally constructed. And that was 1,600 patients, followed up for almost 3 or 4 years at these sites. So, last thing here. This little chip I mentioned, called the CardioMEMS chip, you can put it in the pulmonary artery. You can actually see what the pulmonary artery pressure in your patient's doing. You then use drugs in a very different way, tailored to the individual, not just target doses, but tailoring it to their physiology. So much more personalized and not just remote monitoring. Big difference in heart failure outcome. And this is the concept that wherever you live, surely you should be able to access best care through these digital means. We need to construct things differently rather than demanding that people come to see us at our convenience. Lots of activity in this space, particularly in heart failure. Big digital summit in Tallinn, one of the most digital countries in Europe, discussing all of these issues. TED-style talks, UN-style panels, patients there, tech developers there, venture capitalists. This is the modern world of trying to move forward. But just on a salutary note, that's fine, that's the cutting edge. How well are we actually doing? This is a recent UK report, people dying in hospital, and I know Roz is following me, so I don't have to emphasize a lot of these points, but the lack of discussion of prognosis, of ceilings of therapy, of escalation of therapy, of diagnosis, of access to specialist care, it's very depressing. This is looking at how GPs do the diagnostic approach. And basically, half of patients in England who end up with a label of heart failure haven't had any investigation at all. They're just given a label of heart failure and some diuretic, and that's it. That is scandalous. So that really does need to improve. This is all of the hospitalized patients in England, most recent report. Now, I don't know which age group you're in. I'm certainly in this age group now. Look at the use of these drugs, life-saving drugs. It goes down from about the age of 50. You've had a good life. What do you expect? Thank you, that was a joke, I'm not serious. This is the use of Entresto. Drugs stopped early access given, fully reimbursed. People complain about NICE being slow. Well, when NICE says yes, yes, cost-effective, clinically effective, this is the takeoff trajectory. This is where NICE thought the drug usage would be. This is where it is now. It's like a jumbo jet trying to get off the runway and just missing the fence at the end. We need to redesign our systems. Follow up 2 weeks after discharge, really high risk period. Everybody should be, NICE says. These are the curves. Even in the youngest age group, we only follow up 70% of patients with any specialist input, and it takes about 6 weeks. God help you if you're a typical heart failure patient. We only follow up 40%. That'll take you 3 months to see anybody. after you're discharged. So we've got a front edge with amazing advances. So if you get good access, diagnosis, and treatment, you will do very well. Sadly, we're not delivering that for most patients. So I welcome the opportunity to share this with you. Thank you very much.